Good afternoon or good morning, everyone, depending on where you are. My name is Saqi Maleque from the National Center for Health and Public Housing. And on behalf of the SDOH Academy and all of our panelists today, I'd like to welcome you to the first session of Reducing Health Disparities Through Community Partnerships. I just want to take a second to thank you and acknowledge you all for joining today. I know this is an extremely busy time for everyone. And when we had originally planned this learning collaborative many months ago, we were thinking about community partnerships broadly, but we've pivoted slightly to ensure that we're providing guidance or examples that can be applied to your current situations. Even though the COVID-19 pandemic is affecting everyone, it has really highlighted the existing inequities in our healthcare system and in our communities. So it's very timely for us to discuss, how we can all work together to address it and improve health and well-being for everyone. Next slide, please. There we go. There is a lag. Before we begin, just a quick reminder that we are recording this session, so your phone lines have been muted. If you do have any technical difficulties, please just let us know through the chat box. Danielle, who's one of our faculty members, will work with you to resolve any issues. Okay, next slide. Okay, so this year, the SDOH Academy has developed a series of learning collaboratives that are targeting staff from health centers, primary care associations, and health center control networks. We did have a chance to look at the registration list, and it seems that there's a very diverse group of people that are registered today. There are two 90-minute sessions for each learning collaborative. The first hour consists of presentations, and then the last 30 minutes are an office hour where you can ask questions and have an opportunity to discuss challenges and solutions with the other folks that are on the call in a more informal way. I will say, though, that if you have any questions, please do drop it in the chat box. That way everybody can see it and respond in real time, and then we can pick up on it later during the office hour. Please register for each session that you plan to attend. We created separate links so that you can pick and choose which sessions you'd like to participate in. And the recordings, of course, will be available on the SDOH Academy website. Next slide, please. These learning collaboratives are developed by faculty from 16 wonderful organizations that are all working to improve access to care, address health inequities, and improve the quality of life of vulnerable populations. And you can visit the SDOH Academy website for more information about those organizations. Next slide. So this is the third learning collaborative from the SDOH Academy this year. In February, there was a learning collaborative on improving access to care. In March, there was one on fostering a workforce that is able to address emerging needs. And the recordings and the slides for both of those learning collaboratives are available on the SDOH Academy website, so please check them out when you have time if you haven't already done so. This month's learning collaborative is focused on enhancing population health and addressing health disparities through community partnerships. And the next month's learning collaborative is on understanding emerging issues. So please register for that one if you haven't already done so. Next slide, please. The learning collaboratives were developed to help health centers, PCAs, and HCCNs master the following core competencies. And you can see that those competencies closely mirror the titles of the session. The core competencies for this month's learning collaborative are to build capacity to address SDOH through partnerships and system delivery transformation. Next slide, please. So to accomplish that, we have a great panel of presenters from Capital Link, National Center for the Equitable Care for Elders, National Center for Health and Public Housing, and the National Center for Medical Legal Partnerships. Next slide, please. So here are the bios of our presenters today. Ms. Allison Coleman is the Chief Executive Officer and one of the founders of Capital Link, and she's responsible for overseeing the organization's services that are provided through 7 offices across the United States. She is an expert on health center financial performance and has worked extensively with leaders in the health center sector to develop technical assistance programs designed to strengthen health centers financially and operationally. Allison has an MBA and an undergraduate degree from Yale. Our next presenter is Arielle Mather. She is the program manager for the National Center for Equitable Care for Elders, and she oversees the planning and the delivery of the center's trainings and technical assistance activities. She spent many years in the Boston nonprofit sector addressing the needs of older and vulnerable populations, as well as the providers who care for them. Arielle has a Master of Public Health from Tufts University School of Medicine, where she concentrated in health communication. As I stated earlier, my name is Saqi Maleque. I'm the Director of Research Policy and Health Promotion at the National Center for Health and Public Housing, and I've been working in the SDOH field for the past 15 years, and my expertise is in the intersection of housing policy and health, and I received my doctorate in public health from George Washington University. Next, Ellen Lawton is the Principal Investigator and Lead Research Scientist at the George Washington University, where she co-leads the university's National Center for Medical Legal Partnership in the Department of Health Policy and Management. She is an expert in poverty law and is internationally recognized for her leadership in developing the medical legal partnership approach. She received her law degree from Northeastern. Danielle Rahajason is the Administrative Coordinator for the National Center for Medical Legal Partnership. She's responsible for managing all the administrative functions related to the center's portfolio. She serves as the first point of contact for coordinating services and information referrals, and she works closely with staff and program officers and partners to support daily program operation. Okay, next slide. So our learning objectives for the Learning Collaborative are to build partnerships in the community, to build capacity on integration of services, to discuss strategies to employ delivery system transformation, and to explore opportunities to improve data analysis. We will be addressing some of these learning objectives today, and then the other ones we'll be tackling in the deeper dive that happens in our next session. Next slide, please. We will be sending a brief evaluation survey at the end of the session, and we ask that you all please take a few minutes to fill that out. Your feedback really helps us to improve our sessions and plan for the next round of activities, so thank you in advance for doing that. And now I'm going to pass this on to Allison to talk about her organization's COVID response. Next slide.
Hello, everybody. Thank you so much for joining the webinar today. I know we all have COVID-19 kind of on our brains all day, every day, it seems. And one important lesson that I have relearned in this time is that working with partners is critical, since the scale of the need that we're facing with COVID-19 completely dwarfs any one organization's capacity to respond. So I think this discussion today about community partnerships is particularly apropos. I wanted to share with you a few of the partnerships that we have been focused on at Capital Link to assist with COVID response. And most of these partnerships that are most active right now are working in close collaboration with NAC and with primary care associations. We are particularly focused on helping health centers survive and recover, hopefully financially, from COVID-19. We have a large national database of health center audits, and we've used that information to try to estimate revenue loss at health centers as a way to help NAC and primary care associations understand the scale of financial challenges that health centers are facing. We've shared our estimates with NAC, and that's become the basis for some of the federal outreach and education that they have been doing, and likewise with primary care associations, many of whom are reaching out to various funding sources to try to help health centers. A number of articles that some of you may have been seeing over just this last weekend rely on some of that data analysis, and we're happy to be able to support the field in that way. Next slide, please. Another collaborative activity that we're undertaking is a project to help curate the list of resources available for health centers in terms of grants and loans to help them financially through this time. We've developed a very large listing of resources. It's available on our website. It's also available through the Health Center Clearinghouse. We are working actively with a number of lenders across the country who are working both related to some of the SBA loan opportunities for health centers, but also we're working with a group of 25 community development financial institutions, CDFIs, looking at longer term response beyond the immediate funding opportunities that may be available through SBA. To help stabilize health centers financially in the coming years as we get past this pandemic. And likewise, there are a number of foundations and lenders who are interested in setting up and deploying emergency loans and other resources to health centers, and we are acting as a resource to them to try to facilitate their making capital available for health centers. And that's it.
Thanks. So I just wanted to briefly talk about the U.S. Department of Housing and Urban Development's response and guidance to public housing authorities with respect to COVID-19. So HUD has a COVID response webpage, and on that webpage, it includes information and resources and really stresses the opportunity for housing providers to work with health departments to prevent the spread of the virus. It also directs people to the CDC website. It also includes an 8-page long FAQ document for public housing residents and voucher recipients that's being updated every 2 weeks, and it has guidance on things like how to implement social distancing policies, communicating with residents and resident councils, keeping the buildings clean and sanitized, and what resources are available to pay for PPEs and much more. We've been working with HUD on the updates, and if there's anything that you would like to make sure is on there, we can communicate that with them. So just please add your suggestions in the chat box. Another quick thing is that HUD announced in mid-March that it will encourage local PHAs to suspend evictions on public housing residents, but it doesn't have the legal authority to do so. It doesn't have it's not able to force PHAs to do so, and the moratorium doesn't apply to housing choice voucher holders. So just from as a point of reference, there are twice as many voucher holders, around 5 million, compared to public housing, which is around 2 million individuals. Next slide, please. So this is just a local example from the Phoenix Housing Authority on how they're addressing COVID-19. Many of the items are related to how to implement social distancing to prevent the spread of the virus, but continue to provide essential services to residents, acknowledging that COVID-19 might jeopardize housing stability, so suspending evictions and penalty fees, and extending payment agreements and deadlines in order to make sure people are able to stay in their homes, because homelessness is certainly a health issue. However, there are also some, I think, unintended consequences of the social distancing policies that may affect health, such as the suspension of home visits and caseworker visits and even pest control. So it'll be very important for housing authorities to work with health partners to coordinate the care of their residents. And that's the guidance that we've been providing to housing authorities. We tell them that things are changing very rapidly, and they should contact their local health center directly for up-to-date information and guidance on local resources. For example, last week, everyone was really concerned and wondering whether or not their staff should be wearing PPEs, and now we know that the CDC is recommending, masks for people when they're in public situations. So having the ability to update it, these documents quickly, and being able to have these open communication lines between community health centers and housing authorities is extremely important at this time. If you would like to contact your local housing authority directly or for any other issues, but you don't know who to talk to, you can go to our website. We have an interactive map that displays all the health centers and their proximity to public housing development sites and authorities, and you can kind of zoom in and click on your neighborhood and see where the development sites are around you and the contact information for them. Next slide, please. And just one last thing I'd like to highlight is a positive story from the city of Williamsburg, Virginia, and what they've been doing to address the real and very important need of accessing food during COVID. And in Williamsburg, the city purchased food from local farmers market vendors for public housing families, and the city manager approved the purchase, and then the Williamsburg Human Services staff reached out to members in the community to identify who was having difficulty accessing resources, and then worked with community partners to coordinate those services. And then social workers were able to identify who was at risk if they left their homes. And even though this example doesn't include a health center partner, I do know that there are many health centers that are directly involved in working with local food pantries to offer drive-through pickup as well. Next slide, and this is for Arielle.
Great. It was nice to have a positive story, Saqi. Thank you for that. For the National Center for Equitable Care for Elders, our goal during this time is to make as much information available to health centers and lookalikes from reputable aging organizations around older adults, as they are certainly always a very vulnerable population, but especially so at this time. They might be isolated at home without their normal supports, or if they've tested positive or receiving treatment, they may not be able to be visited by family. Could be some significant family or caregiver stress as well. Unfortunately, a number of older adults also have multiple chronic conditions, which heightens their risk for complications from a variety of factors that, of course, include their age. Organizations like the National Council on Aging have done a really fantastic job, though, with compiling resources for both providers, including those at health centers, and then patients and their caregivers related to SDOH needs and services available in states and counties across the country, such as transportation to necessary medical appointments and services like Meals on Wheels. I would encourage you, when you have the copy of these slides, to visit these pages, both for older adults and their families, as well as providers, for the most up-to-date centralized information about the available services in your community for this population. I do want to mention that the USDA Food and Nutrition Service has given states options to make it easier to get SNAP food assistance during this time and temporarily raise the SNAP benefit amount. The need for food assistance, as Saqi mentioned, especially for older adults, will continue to grow during this time, and Feeding America is building inventories of emergency food boxes to distribute to food banks across the country, as well as providing those food banks with emergency grants to support local response efforts. And aging organizations like Friendship Works here in Boston have been working for many years to reduce social isolation by matching volunteers to older adults in need of assistance with errands or going to medical appointments with them, or even just companionship. Agencies like this during this time are continuing to support older adults with regular phone calls and the addition of virtual visiting with a little help from technology, and are continuing to explore alternative connection options to support older adults who are aging in place in their communities. Next slide.
Great, thanks, Arielle. This is Lawton. Hi, everybody. I'm at the National Center for Medical Legal Partnership with my colleague Danielle. And apologies for this a little bit fuzzy slide, but what we do at the National Center is to help PCAs and health centers and lookalikes to develop partnerships with local legal resources, public interest resources, typically with law schools or legal aid agencies or other legal resources that can help them tackle some of the complex social determinants of health. And so, of course, in the COVID era, we're seeing lots of different social determinants of health challenges, and many medical legal partnerships that are actually active in health centers and hospitals around the country that are trying to work remotely and to reach clients, but also to support clinicians with a range of emerging needs. And so we ran a webinar last week for about 300 MLP sector leaders and lawyers, clinicians, and others thinking about issues like housing, issues like immigration, homeless folks, domestic violence victims, et cetera, people who are in need of legal resources, and how can we best meet that need in this particular era. And so just direct you to our website for lots of different creative strategies that programs are putting together in order to double down on some of the challenges that the community health centers and PCAs are seeing with the populations that they serve. Thanks. Next slide. I think. Yeah, great.
Okay, so now, thank you, Ellen. So now we're going to start with our overview on how to develop cross-sector partnerships. And I just want to start with a quick plug. Last year, NCHPH and the National Center for Equitable Care for the Elders and the National Nurse-Led Care Consortium worked together on an SDOH Academy Learning Collaborative focused on building partnerships. And we just developed a guide based on the findings and the discussion from that learning collaborative, and much of what we're presenting today is also referenced in that document. And so hopefully that resource will be available to you by our second session, which on April 22nd. Next slide, please. So when we talk about health disparities, we are referring to a difference in health status or outcomes that's closely linked with a social or economic disadvantage. Health disparities adversely affect groups of people who've systematically experienced greater social or economic obstacles to health, or in a clean environment based on their racial or ethnic group, their religion, their social and economic status, their disability, their sexual orientation or gender identity, or a whole host of other characteristics that are historically linked to discrimination or exclusion. Next slide, please. And we often discuss health using this metaphor of a stream, with upstream factors bringing downstream effects. And I think there's been a little bit of confusion about the difference between interventions that address social needs versus the social determinants of health. I think sometimes we use those phrases interchangeably, but they're actually two different things. So when we talk about social needs interventions like screening and the use of community health workers, those create a middle stream. They're further upstream than medical interventions, but not yet far enough. So social needs are like the downstream manifestations of the impact of the social determinants of health in the community. So this diagram comes from an article by Castrucci and Auerbach, where they argue that these individual level interventions are very important, very beneficial, but they aren't long-term fixes. What we also need are community-level changes, like the ones that address housing quality, access to healthy food, availability of low-cost exercise options. Those broader community-level changes can only really be made through policy actions. And so the authors argue that it is a combined effort that needs to take place if we really want to improve health the population level. Next slide, please. And I think the examples that my colleagues just provided with respect to their COVID-19 efforts really display the importance of partnerships. When a group of stakeholders that are committed to improving the health and well-being of their community come together, their partnership really can serve as a very effective vehicle for collective action. When they align agendas and goals, they provide an integrated approach to delivering services. There really is a huge opportunity to reduce and eliminate health disparities. Next slide, please. Okay, just another quick plug for a publication we did on partnerships that were formed to care for the elderly population living in public and affordable housing. And that resource can be sent to you guys in a follow-up email as well. So through qualitative interviews with health centers, we identified a list of programs and funding mechanisms that health centers developed to care for the elderly population. Many of them linked to social services like the SASH program and the PACE program. There are also programs that address one of the biggest challenges for elderly and public housing residents, which is transportation. So it discusses the use of mobile services. And then the Peninsula Sequoia List example actually came from last year's SDOH Academy Learning Collaborative. So please take a look at that document for more information and links to those programs. Next slide.
Great. Fantastic. So let's now review what partnerships in your community can look like, goals for those partnerships, and considerations for keeping these partnerships effectively meeting the needs of your patients over time. Next slide. I'd like to first mention this idea of a medical neighborhood for those of you who might not already be familiar. The Patient-Centered Primary Care Collaborative defines a medical neighborhood as a clinical community partnership that includes the medical and social supports necessary to enhance health, with the patient-centered medical home serving as the patient's primary hub and coordinator of healthcare delivery. The goals of a high-functioning patient-centered medical home include collaborating with these various medical neighbors to encourage the flow of information across and between clinicians and patients, to include specialists, hospitals, home health, long-term care, and other clinical providers. As you can see on this slide, the goal is to have a map of the medical neighborhood documented so that everyone on the health center team can understand what resources may be helpful to connect a patient to, and you're all working from the same point of reference. Of course, depending on the city or state that you live in, the way that a medical neighborhood may be structured could look quite different than for someone else participating in today's session. And there's certainly a lot of flexibility in how a map of your medical neighborhood can look as well. I'll show you an example in just a moment of a more involved map that has the patient in the center and the available partners branching off, but it could be as simple as an Excel list or even an up-to-date bulletin board in the health center hallway. A map is meant to be a helpful resource that provides quick access to information that can address potential challenges in the lives of your vulnerable patient populations. Next slide. So here is an example of a care map that was actually presented at the IHI European Forum in 2014. So a pediatrician had asked a patient's mother to draw a visual representation of the resources that she coordinated for her son, so that the doctor could better understand the breadth of services accessed by children with special healthcare needs. So this figure represents this particular patient's medical neighborhood, depicting the supports he needs across sectors to live a full and healthy life. Again, this is pretty detailed and is patient-specific, which is a great option for a medical neighborhood map, but you may need something more general and population-specific in your practice. But let's talk about how to begin the process of identifying medical neighbors. Next slide. All right, so no matter what it looks like, creating a care map is founded on the goal of promoting wellness for either that individual patient or population, like older adults or residents of public housing. These are not something that are created just by you as a staff member, but are hopefully put together collaboratively with patients and potentially even their families, especially so you can get more context about how certain community services are used, some real life examples of how they can support overall health. The patient or the wider population is always at the center. It's also important to mention that these care maps may look different over time, maybe should look different over time, as needs or life circumstances change for a patient, or in taking into account the various social determinants of health that could be at play at any given time. Next slide. So as we mentioned, the number and capacity of community organizations near you is definitely going to vary by location, acknowledging that currently some of those organizations may be even more active during a crisis, or unfortunately limited in their services due to restrictions or funding concerns, but certainly an essential part of creating a care map for a patient or a patient group is to understand who is operating those services in your area and knowing exactly how to reach someone there for questions and just generally for your ongoing work together. And since turnovers can and do happen, it is helpful to understand what plans are in place to continue services and maintain a connection if staffing changes. Next slide. If some of the organizations that you've identified in your community are interested in working together, a Memorandum of Understanding, or MOU, is a formal written agreement that can help outline the level of participation and involvement in your partnership. The format of this contract may depend on organizational preference, but can be generally used to establish ground rules for collaboration. This protocol can help organizations to have a clear understanding of purpose, a mission statement of sorts, as well as to really target the focus areas. You can see some examples on this slide. An MOU is also a great opportunity to be on the same page with other organizations about the words that you're using to advertise a service or talk about the population that you're serving. The difference between using elderly or older adult might seem small, but using the same term consistently will send a unified message to others about your partnership, particularly when you're using language that is used to talk about patients or groups of people. And finally, MOUs can help define the initial length of a partnership, particularly if there's a limited source of funding or a defined period of time that you're willing to work together. It is important to be in agreement about whether or not to continue services or support after a potential loss in funding, whether that's anticipated or unexpected. Next slide. All right, so a well-functioning medical neighborhood takes the resources and inputs that include patients and their families, providers, community services, local agencies, databases, health IT, and more, and begins to involve, educate, and promote a referral and communication system that hopefully results in improved information flow, increased engagement, better understanding, and increased accountability for all parties. The outcomes we'd like to see in the short term, this type of neighborhood should be able to see outcomes of improved care coordination for patients, along with better patient safety and more positive overall experience for a patient receiving care and support. And then over time, a well-functioning medical neighborhood should be able to influence better health outcomes, reducing duplication and therefore reducing waste or cost, and generally promote improved population health management. So a lot of benefits of a well-functioning medical neighborhood. We're going to shift slightly now from the specific concept of a medical neighborhood and discuss partnerships a little more generally in all their various stages. Next slide. I do want to briefly mention that there are certainly different levels of partnership. Not all partnerships look the same and often can develop over time with increased capacity and levels of support. There are benefits to organizations involved at any of these stages that you can see on this slide. So networking includes information sharing between groups. Coordinating it includes, in addition to all the good networking, information sharing, you're aligning your activities to meet a common goal. If you're moving on to cooperating, you are, in addition to networking and coordinating, sharing resources or a space, likely through that written contract. And then collaboration is including all of the previous stages and enhancing your capacities through seeking mutual feedback. So encountering barriers on the way to building and developing partnerships is common. Roadblocks to effective partnerships may be a result of limited resources or a lack of understanding or openness in new relationships. These barriers can often be overcome, in part by identifying a shared vision and incorporating the missions of all who are represented. Next slide. Great, so we'll briefly walk through here the early, middle, and later stages of partnership formation, which may be familiar to some of you who were able to join us in our partnership-focused learning collaborative through the SDOH Academy in 2019. At the very beginning, it is certainly important for organizations involved to clearly define each of their roles. Distributing responsibilities in a way that's realistic and achievable for everyone will ensure potential barriers of time or imbalanced effort can be avoided. Open communication can help to build trust in a new partnership, particularly to establish a clear plan around how goals will be set and decisions will be made. A collaboration that has a wide variety of perspectives and life experiences is going to be able to effectively speak to the needs of the community as a whole. Valuing diversity in a partnership with individuals who have different backgrounds than our own can allow for personal growth and an expanded worldview. The common goals that often spark a partnership can help to shape the way a group talks about its mission and approach amongst not only each other, but the larger community. A commitment to staying engaged in the collective work will ensure a partnership can be maintained for the long term. Next slide. Great, so when it comes to the maintenance of partnerships, once organizations are on board, there should be clear ground rules about standards of conduct, meeting frequency, and task management. This is where you would want to make sure there's an MOU in place. While all members can play an important role, it can be helpful to identify and maintain a core leader or leadership team to keep track of goals. Those in a leadership role should be committed to navigating the group through changes, including identifying future projects and potential collaborators. Aiming for multiple sources of financial support can allow partnerships to secure sufficient funding that is sustainable over time. Health center patients should be informed that partnership services are available. It may be feasible to provide information directly through the electronic health record or patient engagement channels if the programming addresses chronic conditions, for example. Discharged staff members should also be informed of the services available to patients. Hopefully signage can be placed at the reception desk or waiting area so they can be seen easily. Clear communication about the availability of resources and a common understanding amongst health center staff about the benefits for patients will certainly assist in encouraging participation and satisfaction over time. And certainly maintaining these healthy partnerships does require conflict to be addressed in a prompt and direct manner. Leaders may need to embrace the initial discomfort of talking through a disagreement in order to avoid long-term consequences. Depending on the size of the group, opportunities for feedback may be approached with more casual asks or scheduled times for reflection. A willingness to revisit an approach and make necessary changes will allow the group to continue to effectively work towards agreed upon goals. Employee turnover or other staffing changes at an organization may lead to delays with projects or meetings, but that clear documentation of roles and responsibilities for all involved will hopefully allow for new employees to be accurately informed about the details of the partnership and any relevant timelines. Go to the next slide. And finally, when it comes to evaluating partnerships that you're involved in, there are several approaches depending on the level of resources and potential stakeholder expectations. Some initial important questions to ask would be, who is the evaluation for? Maybe what are their priorities? What do those evaluators want to know? Maybe what targets does the partnership want to reach? And then of course, when do they want to reach those targets by? If you have evaluators, they'll be able to look at a partnership's progress over time if clear objectives have been developed and if those involved in the work are all on the same page about how best to achieve them. Core leadership should oversee the organizational process, and communicate to the group how much time and analysis the evaluation will require. However, including all involved parties in the evaluation process can continue to strengthen group rapport. The evaluation of a partnership focused on better health outcomes for a specific community will not provide sole credit for a long-term positive change that occurs in the target population, particularly if there are other organizations working towards a similar goal. However, this does not detract from a collaboration's positive contribution, as an evaluation can help identify the most effective short-term efforts that were made. The result of this evaluation should be shared with all groups that are represented in an interested and invested audience, including stakeholders, potential future collaborators, and any others who might be affected by the results. Next slide. Great. So we're going to have the opportunity in our second session on April 22nd to dive more deeply into a couple of case studies around reducing health disparities through community partnerships, but we still wanted to offer some examples today of how these arrangements can benefit patient populations and the variety of forms these partnerships can take. Next slide.
Okay, thanks so much, Arielle. So this example involves an interesting public and private partnership between Olivio Medical Center, which is a federally qualified health center, the Resurrection Project, which is a nonprofit community development corporation, and the City of Chicago. So these three organizations worked together to create Casa Maravilla, which is a senior center that houses seniors 55 and older, and it has 73 independent apartments. The relationship between these organizations began when community activists realized that the population in the community was aging and there really were no affordable housing options for seniors. Resurrection Project was also interested in building a development that anchored the community to fend off gentrification as much as possible. So they approached the CEO of Olivio Medical Center to purchase some of its land that it owned north of the medical center. And Olivio agreed with just one condition, that some of the land was reserved for a senior building and a senior center. So the Resurrection Project contacted the City of Chicago's Department of Family Support Services, their senior area agency on aging, to discuss creating a satellite senior center. And since Olivio was experienced in providing care to seniors, the Resurrection Project asked them to manage the site. So the way that it works is that the Resurrection Project owns the building and they lease part of the first floor to the City of Chicago for the senior center, and they do that at no cost. And then Olivio Medical Center manages the senior center, and they do that at no cost. And this unique public-private partnership has extended care to over 6,000 seniors in the area. And the senior center also has monthly wellness programs, so they have a nurse, a dietitian, and a pharmacist that provide health education presentations for seniors. They also have outreach and enrollment staff housed at the site. The senior center also operates as a benefits enrollment center, and they also work with local school programs to allow students to work or volunteer at the center, which is really beneficial for both age groups. One of the unique characteristics of this community is its diversity. The area is multilingual and multicultural and is very important to the leadership that the staff at the senior center is a reflection of that. So they have an all multicultural staff. And one of the challenges that they've faced has been misinformation. So seniors are often unaware of the programs and the services for which they are eligible. So through funding, through the National Council on Aging, Casa Maravilla can screen and identify programs and services that are needed. And that partnership continues to grow. On land purchased from Olivio, the Resurrection Project has just completed a construction of a $15 million development called Casa Moreos, and it's a green building, and it has an additional 45 units of affordable rental housing. Next slide.
Great, thanks, Saqi. This is Ellen Lawton again, and I just want to give you a little example of a medical legal partnership, cross-sector partnership, that we did a case study on at People's Community Clinic in Austin, Texas. And that's available on our website, and maybe Danielle can post it in the chat for everyone. And it tells a great story, and this is, I think, very relevant to the content that you just heard from Arielle and Saqi in terms of what are the components of a solid partnership. And so what you see here is a timeline of core operations and growth for the medical legal partnership at the People's Community Clinic. And it really tells the story of how it took some sorting out. And it took them some time. This tracks over 6 years in which they were experimenting with different ways to bring legal services on site into the health center, figure out how to fund it, figure out how to organize it, figure out how to set priorities and to integrate those services as part of the work that they were doing within the health center, how to align leadership priorities from the two organizations that are partnered together. So again, all themes that Arielle and Saqi highlighted in their review of how do you build a solid partnership, what are some of the components. And so I would look at this case study, if I were you, for the purposes of first understanding that it does take time to sort out. Some of you, I'm sure, on the call today are thinking about medical legal partnerships or linking with your legal partners in your community, and really feeling even more pressure now in the COVID era to try to get effective team members to support both your clinicians and your families and patients. And so what I would say is it's not axiomatic that it's going to take you 6+ years to sort things out, but to say that everything begins with one step. And so the story of the Austin People's Community Clinic is that they started somewhere. And that's what you can do out in your community is that you have to start somewhere, and you have to stay open, and you have to be attentive to things like funding and boundaries around practice and setting a vision together. And what you heard in terms of Saqi's case example, I think is really terrific, which is that after building some trust between the organizations, they were able to even go even further. And I think that the Austin People's Community Clinic demonstrates that principle as well. So I think this is applicable whether you're just getting started, whether you're kind of in the middle of trying to sort out a partnership, or whether you've had a partnership active for some time and now you're thinking about growth, or you're thinking about pivoting your focus. And all of those steps, they still build on foundations that were articulated earlier in earlier slides. So I'll stop there. Next slide. Great. And just in terms of resources, and again, to give you examples to wrap your head around, the Build Health Challenge has been, as you can see, they strengthen partnerships between local nonprofits, hospitals and health centers, health systems, and local health departments to improve community health and well-being. And so they have invested in, I think now close to 30 programs around the country that are experimenting with strengthening or growing collaborations across these entities. And they have lots of lessons to share, lots of great tools that they've developed to help people develop MOUs, to develop measurement tools, to think about what it takes to build a successful partnership. So I just recommend that you check out Build Health Challenge, and you may see that there's one in your community that you could reach out to get some guidelines or insights from. Great, I'll stop there. Thanks.
Great, next slide, Danielle. Fantastic. So I wanted to mention a resource that the team came across recently, an article and a corresponding pilot project report on the Community Care Connections program based in Rochester, New York. The overall goals were to evaluate and inform effective approaches to integrating community-based aging services with medical systems of care to ultimately provide a successful, replicable integration model. This program provides a trusted point of contact for providers and patients around non-clinical health issues. They try to close the gap in communication through supportive relationship building with case managers and follow up with providers after intake. They try to allow time for whole person care planning through detailed assessments. And so their evaluation report showed results of decreased hospitalizations, decreased emergency department visits, and decreased healthcare costs overall for these older adults. So I would encourage you to take a look at both the article and the very comprehensive report if you're interested in seeing an example of the way these cross-sector partnerships can benefit older adult patients. Next slide. And with that, we have some time for questions. I believe Danielle is going to put up a poll question for the group. We'll give that a moment, but we'd love to hear a little bit from those in the audience today. So for you, what do you think is the hardest part of building cross-sector partnerships? So acknowledging that there could be some different groups on the line today, we are interested to know, from your perspective, is it aligning missions? Is it funding, staffing, maybe tracking outcomes? So we'd love to get your responses. We can give that a moment, and certainly you can utilize the chat box to put in any other questions that you might have. Danielle, I'm not able to see any slides while the poll is up, so we can give it a moment or two and then close it.
We have about 55 people, 55% who have voted so far.
Great. We'll just give it maybe a couple more seconds in case you're still thinking about which one you'd like to select as far as for you and your experience in your location, the hardest part about building these cross-sector partnerships. Okay, Danielle, I think we can close it if you want to. I think you mentioned it will show the results to everyone. Okay, so funding is a big one. I see 46%, and then the other three, there was still some concerns across the board. Okay, that's very helpful. All right, so we can give it still a moment or two if there are any other questions or comments.
Arielle, this is Ellen. I'm happy to dive in a little bit deeper on I responded to the question that came out regarding who should I get in touch with in the health system.
Sure.
So I'm happy to dive in there.
Yeah.
If that would be helpful, sure. And I just saw came up the biggest problem for one person is getting getting management to partner. They want to go it alone. And so this kind of goes to the question that somebody asked about a health system. Who is the best person in a health system to engage in terms of forming a cross-sector partnership? And I just think that's a really great question because health centers and health systems can be many-headed beasts, right? Some health centers are quite small and the hierarchy is relatively flat, but health systems can be enormous organizations with multiple power centers, and so it can be hard to identify who is the right person or people to lead a partnership. And so an example of that is in the medical legal partnership realm. Often the general counsel becomes involved because they're a lawyer, and it makes sense to involve a lawyer at a healthcare institution to partner with a community legal organization. But in reality, what we found in the medical legal partnership world is that while you want to have someone who's really truly committed to forming this partnership, so that I think that passion factor has to be there, and along with understanding what the value of the partnership is for the institution. You also probably want several perspectives across an institution. So you may need, for example, the enabling services director, as well as the clinical director, as well as the COO. And so I think that perspective of having multiple people engaged and aware of a partnership, even if there's only actually one or two people that are driving the activities, I think can help to eradicate some of the challenges that commenter just referenced, to that go it alone kind of mentality. And we dive into that in the case study in Austin about what the leadership engagement was, what the board engagement was, because there was a board challenge. Folks on the board at the health center weren't necessarily interested in investing in medical legal partnership, but came around ultimately to support the work. And so I think you have to be flexible in looking for your champions and not try to zero in on a single person or two. So, but I invite my colleagues with other perspectives. Just wanted to share that response.
Yeah, that's great, Ellen. And I do see another question in the chat box around, picking a single group to focus on. I assume who's benefiting from a partnership versus focusing on the wider community. And I'm wondering if we could dive a little bit more deeply into that in the office hours, if the individual asking the question has the time to stay for that extra half an hour. I do want to be able to get to our quick teaser of session 2, if that's okay, from Allison.
Sounds good.
Great.
Sure, great. Hi, everybody. It's Allison Coleman from Capital Link again. I want to give you just a very short preview of what will be discussed in much greater depth at the second webinar in this learning collaborative that will be held on April 22nd. And this is an example of a health center in Brockton, Massachusetts, who collaborated with a grocery store. Together, these two organizations redeveloped what had basically been a derelict warehouse that had been vacant for about 20 years. It actually had been a grocery store, several decades before that, and had closed down. And the owner of Vicenti's Tropical Grocery was a very small grocer in Brockton and was looking to expand. And at the same time, the health center was also looking to expand. And this particular project was really, physical facility was really too large for either of them to take on individually, but together they thought that they could do it and that it would bring some significant benefits to the community. So they worked together to develop this collaboration. It was financed through a $22 million investment that was financed through the New Markets Tax Credit Program. And it built 1,600 square foot health center and a 40,000 square foot grocery store immediately adjacent. Next slide, please. A bit about the context that really gave birth to this collaboration. Brockton is a city south of Boston, has a population of about 95,000. It is a largely African-American, Latino, and immigrant community. Have a very large Cape Verdean population and many Caribbean immigrants to the area. And the Vicente market had as really its specialty providing very fresh fruits and vegetables from all over the world, but with a specific focus on Caribbean foods that were really attractive to the population in Brockton. Brockton has very high unemployment rate, about twice the Massachusetts rate. Likewise, the diabetes rate was very high. About 10% of the population was diagnosed with diabetes, and the health center saw that as a particular challenge that it wanted to try to address, and believed that access to food was a key component of that they could not really solve on their own. Brockton has a high poverty rate and is classified as a food desert. Go to the next slide, please. Just a couple of features of the collaboration that, again, we'll be talking with Sue Joss, the CEO at Brockton Neighborhood Health Center on April 22nd, and she will dive into many more of these details. But what the store really wanted, the grocery store, they wanted to be able to expand and continue serving their population, but they just needed more space to do that better. And they really saw this niche that they brought to their community, bringing kind of native foods to their population, really made Brockton feel like home for their heavily immigrant population. And so they were bringing their grocery expertise. They also were interested in providing more detail and nutritional guidelines and labels on the shelves to help people make better food choices. And that was really something that came out of dialogue and discussion with the health center. As I mentioned, the health center was really interested in focusing on improving health outcomes of its diabetic patients. And as part of the project, in the health center side of the facility, they added a teaching kitchen that is staffed by dietitians and health workers. And there also is a television feed that goes into the grocery store so that they will have food preparation demonstrations and various educational events that will be held in the teaching kitchens, but broadcast throughout the grocery store as people are shopping. They also collaboratively developed a reward system to encourage healthy choices, so that if patrons of the store bought certain, vegetables and decreased things like chips and things like that, they got certain points towards groceries bought at the store. And a lot of what I think Sue is going to talk about when on the 22nd is how they developed some of the clinical programs in collaboration with the grocery store as a willing partner, and some of the ways that they tracked health outcomes for their patients and what some of the results and lessons learned were. I should also say that this collaboration, as many collaborations do, has also spawned additional collaborations. The city has made a commitment to building new sidewalks in the area and has made investments in public housing in the area as well, which continues to address other key aspects of health disparities and providing better options for physical activity as well as safety to improve the health of the community. So that's just a little bit of a preview or commercial for the session on the 22nd. We hope that you will join us for that conversation, and we'll look forward to delving into this example more deeply.
Great. Danielle, you can go to the next slide because we have that info for that session on April 22nd. As Saqi mentioned at the beginning, we do have separate registration links for each of these sessions. So we would encourage you, after you are done with this session today, if you haven't already done so, to register for that deeper dive of a session on Wednesday, April 22nd. Next slide. We hope that you can stay for a half an hour of office hours to dive a little bit more deeply into discussion and learn from each other. If you do need to head out, we encourage you to take the follow-up survey that's going to launch as soon as you close out the window. We'd love to hear your feedback. We'd also love to hear your thoughts in preparation for that April 22nd session. Next slide. You can certainly send any of us who helped you put together this presentation today directly. Feel free to take a look at the emails on this slide. Next slide. Yes, so thank you so much for attending the presentation portion of this session. This recording will go up on the SDOH Academy website. If you haven't already looked at the site, I encourage you to do so. It is a great resource for past activities of the SDOH Academy and current recordings and materials from the sessions that are going on this year. So I encourage you to check that out. Next slide. All right, so we are now about 25 minutes left for office hours. I'm going to hand it over now to Ellen and Allison, but we have a couple of questions that can serve as prompts for those who are able to stick around, but also certainly welcome any other questions the group has, and we can kind of have a more open discussion now.
Great, thanks, Arielle. This is Ellen back at you, and maybe you can, one thing I want to kick off is that we did have an unanswered question from the audience. Is it best to pick one group to focus on and not the community? And if I understand that question, I'm going to take a stab at it, and then maybe Allison can take a swing at it as well, but also happy to have anybody out there respond, and Danielle can share your response with the entire audience. My experience from a medical legal partnership perspective is that you have to start somewhere. And so we had an article about our work in Health Affairs a couple of years ago, and one of the principles is around targeting populations. Not permanently necessarily, because there are some medical legal partnerships that serve everybody in a health center, regardless of age or stage or disease status. And that's certainly a principle in health centers. But oftentimes the most effective programs are the ones that are thinking carefully about how to get started and are targeting a particular population, a particular status, a particular problem. It may be housing issues for folks with asthma. It may be income and support for moms of young children. It may be special education needs for certain kids. And so there are all kinds of ways in which you can think about building partnerships that are going to tackle one particular problem, population, or issue. But it doesn't have to be exclusive. It can be part of your building blocks towards a partnership. And so that would be my one suggestion, is that, as they say in the law frequently, it depends. Allison, what do you think?
I completely agree with the idea of you need to start somewhere, and very often when starting somewhere is you need to start somewhere specific. And I think that what we're all being asked to do with these broad community projects to affect health more broadly, I mean, basically, what we're being asked to do is solve poverty. And that's too much for any one group or even any one collaboration to really try to resolve. But I think if you pick something that is meaningful in your community, that you can, that there are a number of folks who are interested in working on this need together, part of, I think, the benefit of starting with one population or one issue that you're trying to address is that it allows you to make some concrete progress on that issue, and also then build on success to move on to the next project, because partly I think the benefit of working hard on collaborations is that, when people see one collaboration working, they're willing to invest in other collaborations, and ultimately to really affect the health of communities, we need many, many collaborations. But we have to sometimes start, on a smaller scale, or something where there can be a positive outcome that's achieved. You notice in the Brockton project, the health center's initial focus was really on focusing in on care for their diabetic population. They had a large diabetic population with diabetes. It was a major focus of their clinical effort, and so they started there. But in reality, though they focused on that, the relationship with the grocery store and the access to healthy food really affected certainly much more than just their diabetic population. So sometimes, even if you think you're starting with a project that affects a smaller subset, it may end up actually having broader reach over time.
So I want to thanks for that, Allison, and I just want to add on to that. And again, folks who are out there, and if you have questions, specific questions about partnerships, or critique or comment about partnerships that actually haven't worked out so well, because I think we have some prompting questions there on the slides. If Danielle, you want to go to the next slide there. There we go. We'd love to hear what concerns to Allison's point. They were focused on diabetes at the health center, but they ended up being able to have an even broader impact beyond diabetes with their focus. I think we see that in the medical legal partnership world all the time, which is that the legal team meets with the health center team to form a partnership, but it doesn't have an anchor in a particular population or a particular issue. And so what we've seen increasingly, particularly around opioid use disorder, is that we encourage health centers to think broadly about the team that they're developing. And this goes to the concern that many of you expressed around funding. And I think that's a real concern, but also cross-sector partnerships demand that you think flexibly about RFPs that are coming across your transom and health centers every single day. And so one leading health center in Indiana, for example, in their OUD proposal included time for an attorney who would work with patients that were affected by substance use disorder. And it wasn't explicitly in the RFP, but what they found was that by including a lawyer as part of the team, that it built the team's capacity in a way that they were able to achieve the goals of the proposal even more efficiently and effectively. And I think those are the types of the flexibility in thinking around, what are we proposing to do? Where are we proposing to focus our attention? And who do we actually need to be on the team so that we can make these goals a reality?
This is Saqi. I just wanted to jump in with an example of how health centers have been partnering with housing authorities on specific issues targeting their efforts. So sometimes health centers have a hard time reaching out to public housing residents, getting them to enroll in their diabetes education classes and continuing to go to the nutrition education groups, that sort of thing. So they have in the past reached out to housing authorities about how to bring those types of programs into the housing community and overcoming some of the resource challenges. And a lot of times housing authorities will have space available, community rooms, that are there and are they're able to bring health center staff in to do these types of health education work at no cost, because they are able to either do it either through an MOU or through a lease agreement where the health center can bring in staff and they can have it regularly and help use that space to improve turnout and enrollment in all of these programs. So that's just one example.
Great, thanks, Saqi. And it's looking like we're not having questions come in, but people are hanging in there still. We're, of course, happy to freelance, but we're also very mindful that folks are super busy and that we're doing a follow-up deep dive in a couple of weeks. And so I'm just checking with my fellow panelists, and if we don't have any additional questions coming in, then what we'd be looking forward to is can we see you on the 22nd, or in the meantime, certainly you have our contact information and reach us offline for resources and follow-up. How does that sound?
Sure, we can, Ellen, we could take some of the, remaining prompts and always keep them in our back pocket for discussion in the next session, as we will also hold a half an hour after that deeper dive session on the 22nd to answer any questions or to have folks learn from each other. So that sounds like a good plan to me. Certainly, as Ellen mentioned, we're available in between now and then for other questions, and we're just wanting to be able to support everyone with whatever concerns they have currently on their minds. And it sounds like a great plan to have everyone register for the next session and see them then.
All right. I think that with that, we're going to close it out. And who doesn't like an early dismissal on a Wednesday? And give you back some of your afternoon, and really thank you for joining us today, and look forward to seeing you virtually and fielding your questions and hearing about the partnerships that you've built, and the ones that you want to build, and the ones that you've built and maybe want to pivot. So thanks for joining us. Arielle, you want to take us out?
Sure. Just a reminder, as you're closing your windows out, you will get a prompt to fill out an evaluation. We'd love your feedback. And thank you so much for your time. We hope to see you on April 22nd.
Thanks, everybody.
Thank you.